Yes, we can.
Yeah. Good morning, sir. You have asked to present a 2-minute talk on Hinman's theory of renal counterbalance. So, in a series of papers, Hinman discussed the importance of problem of restitution of kidney in hydronephrosis. He conducted an experiment in dog where he found a considerable initial recovery of function and repair hypertrophy of kidney after relief of up to 28 days of total obstruction. He introduced the term renal counterbalance. By this, he meant that the anatomic and functional readjustment between the less injured or uninjured portion and the more injured portion in the performance of total work required. In one of the kidneys, if one of the kidneys is removed or destroyed by ureteric obstruction, extra work is thrown onto the fellow kidney, which then becomes hypertrophic. If the obstruction is removed before the parenchyma is destroyed and before the kidney has lost its power of recovery, the urinary excretion is divided between the two kidneys according to certain laws. So loss of a kidney is followed almost immediately by compensatory increase in the work performed by the fellow kidney. Although more or less complete development of corresponding anatomic changes may require several weeks. So hydronephrosis of say like 4 to 6 weeks standing is long enough for the development of complete compensatory hypertrophy of the fellow kidney. So once this stage is reached, the hypertrophic kidney will continue to perform the major part of total renal function even after removal of renal obstruction on the other side. This means that the hydronephrotic kidney will be hardly, if at all, stimulated to function. As the power of recovery of a kidney depends on functional stimulation, so as the restitution is favored most by a gradual increase in such stimulation, it may be inferred that the prospects of recovery of a kidney after prolonged hydronephrosis are fairly poor. So this was the Hinman's theory. Just metabolic evaluation of management
No,
of
no,
recurrent.
hang on. So you understood this, or you just read it, and tomorrow, if I ask you, you will be able to tell me exactly what it's all about
Yes, sir. Yes, sir.
and explain to a medical student.
Yes, sir.
Sure. Eh?
Yes, sir.
Okay. After 1 month, I'll ask you again.
Okay. Okay.
Has everybody understood this concept? It's been proven only in dogs,
Yes, sir.
but it sets a movement for thinking. You know that okay, this is something that's likely to happen, and we see it in our clinical practice. When patient has a stone which is obstructing the ureter, you expect when the stone is removed, the kidney will recover function. In fact, it loses its function, and that is most distressing for the patient. This
Yes,
kidney
sir.
was very poorly functioning. That is why it is very important that when a kidney is poorly functioning, that you assess it before you take the stone out.
Yes.
Before you take the stone out, that means either you do a PCN or do a DTPA or do something. Because what will happen once you take the stone out, the kidney function is likely to go down, and then they will be in deep soup.
Yes.
So this is all very important.
Yes.
Okay.
Yes.
Sir, nice presentation. Can I add some of my views?
Yes, good, Anand.
Yes, sir. Good morning.
You have a colleague here. One friend is sitting here
Okay, sir.
from your country.
Okay, sir. Gokul is there.
Can you guess who it is?
Gokul, I think.
Ah, right, okay. Very
Yeah.
good, man.
Yeah, Gokul said he's coming to Vedanagam anyway.
Oh, so you already knew about it. It's
Yeah.
cheating, man.
Yes, sir.
Okay, ask the question.
Yes, sir. I mean, rather than the question, it's more like a suggestion. So,
Yes.
indirectly, what we can extrapolate from this particular animal or the dog finding is if you are going to operate on a kidney which is obstructed by a stone or even partially relieved by a stent or PCN, if there is a compensatory hypertrophy of the opposite kidney which is documented by the two investigations like previous baseline one and the present one, that should alert the clinician that the kidney which has stone may have already lost the function, because the loss of the affected kidney function happens as parallelly with the hypertrophy. So hypertrophy is an indirect bad sign for the kidney, stone bearing kidney. That is one clue. And the main reason is the body adapts by the extra solute in the body, which is not filtered by the affected kidney. So whatever the growth hormone or the growth related other interleukin hormones are diverted to the normal kidney to make it hypertrophy to function well, so that the solutes are further like dialysed in an appropriate manner. We can extrapolate the same pathophysiology to the testes also. So if you are operating on a testis for any reason, if the opposite testis is got compensatory hypertrophy, then we need to be careful that the affected testis may have already lost the function and it will not recover also. Why it will not recover after removal of the pathology is there is no drive for that affected kidney to grow, because the overall homeostasis is already attained by the compensatory hypertrophy. So the affected kidney will never have that stimulus to grow back to the normal state.
I would agree with you 100%. The sign that we always ask residents is look at the X-ray, and if you find that there is compensatory hypertrophy on the side that is not involved, that's a finding that has to be mentioned on the X-ray, because that will give you what indirect, give you direct evidence that this kidney, the opposite kidney is not good. We see it also in our donors. A
Yes, sir.
kidney donor, we would think that compensatory hypertrophy, look at the pathophysiology, does not occur after a certain age, but it does. Kidney donors do have compensatory hypertrophy after a period, and then it stops. After that, nothing. It doesn't go on growing. The interesting thing is, the so-called extra work that is done to produce this kidney that is big, if this kidney gets affected by diabetes, then the hyperfiltration theory comes in.
Yes, sir.
And that actually destroys this kidney.
Yes.
So diabetic kidneys are big in size because diabetes is one of the causes of large kidney. And if one kidney in a diabetic is gone, the hyperfiltration, Brenner's this thing comes into play. And because the glomeruli are destroyed in diabetes, that is where the kidney functions goes. So hypertrophy by itself must be a normal kidney. If it gets affected by diabetes, that compensatory hypertrophy will not serve the function it should. It will go quickly.
One of the concepts which is taken by Hitman's counterbalance is where are bilaterally affected kidneys are there, to choose which one you need to operate. At this point of time, using this concept, people suggest that you should actually work on the one which is poorer function, one with a poorer function, so that you give extra drive for the kidney to recover better. If you operate a better one, then you are taking the impetus out of that, and then the poorer kidney will suffer more. So this is how all these bench theories are being utilized. So you understand with two concepts. One is hypertrophy, anyway it is known in any organ. Means if compensatory hypertrophy has already set in, that means to say the body has already decided that this is not worthy of supplying nutrition funds.
That's it. I agree with you also on the testes.
Yes, sir.
Many years ago, my professor of pathology who retired from Vellore came to see me because he suddenly found that one testis of his was quite big, and he was 67 years old at that time. And he came to see me. It was not painful. He was very worried that he's got a tumor. So when I examined him, I found that the testis on the opposite side was very small. So I asked him, I said, what happened to the testis on the side? He said, oh, when I was a child, I had a problem and, it just got up. I said, sir, you've got compensatory hypertrophy, a remaining ball. I said, you've done very well so far in your life. No, I think I got a tumor. So I scanned him, I did everything and nothing was wrong. He's still alive with
Yes,
one
sir.
ball which is as large as a football.
Yes, sir.
Anyway, but that's a point well made on it.
Yes,
Okay,
sir.
carry on.
Okay.
There is a condition called macro testis also, volume more than 22 ml is considered a big testis.
Okay. So the prevalence of renal calculus disease has been rising at a rapid rate. In the US, at least stone affects 1 in 11% at some point in their lifetime. The earlier male were most commonly affected. Nowadays, female have greater incidence. According to a couple of studies, there is 50% risk of developing a stone in first-time stone for within 8 to 10 years. Rule et al. Has developed a recurrence of kidney stone normogram to help better predict the risk of a second kidney stone. The predictors of it are younger age, male sex, family history, prior stone event, non-obstructing renal stones, symptomatic stones, uric acid composition. The drawback of this normogram is they have not included urinary chemistries. So the quality of life of a stone formers is lower than the population mean. Women reporting greater impairment. There is also decreased quality of life in patients with asymptomatic stones compared with those who don't have. So metabolic evaluation, here comes the role. It is simple to perform. It is economically viable. It should provide information that can be applied toward a selective rational therapy of stone disease. And in many cases, it helps in diagnosing underlying conditions that can help in preventing non-renal complications. So first-time stone formers, some suggest that they should be provided empirical fluid and dietary recommendation until they suffer a recurrence. Some studies suggest a single stone former placed on a conservative program of high fluid intake alone or combined with avoidance of dietary excess revealed a low incidence of recurrent stone disease. Mostly this has been attributed to stone clinic effect. However, Pack and Strauss et al. Suggested that single stone formers have an equally high incidence of metabolic abnormalities as recurrent stone formers. He conducted a study of 1182 patients. He found that stone formers have 50% of them have hypercalciuria or hyperuricosuriya, 20% has systemic disorder, and 30% has a underlying metabolic disorder. But both first time and recurrent stone formers, 40% of them have hypercalciuria, 45 has hypocitraturia, and 30% has hyperoxaluria. So according to AUA recommendation, clinicians should perform additional metabolic testing in high risk or interested first time stone former. It will also help in diagnosing any underlying disease which help to prevent any extrarenal complications. So high risk stone formers, the risk factors are family history of stone disease, any obesity or metabolic syndrome, any medical conditions that predisposes like hyperparathyroidism, sarcoidosis, GI disease, prior surgical resection resulting in malabsorption, type 2 DM, RTA, gout, and UTI. This is the abbreviated protocol for single stone former evaluation. Comes the history part, a complete history. Complete history taking, underlying predisposing conditions, medications like calcium, vitamin C, and vitamin D intake, steroid intake, any dietary excess, inadequate fluid intake, excessive fluid load. This all should be asked about. Regarding the blood test, there is a basic metabolic panel like sodium, potassium, chloride, carbon dioxide, blood urea, nitrogen, and creatinine levels, calcium, intact PTH, and uric acid. In your urine test, there is a urine analysis, pH, the sediment for crystal urea, culture, and qualitative cysteine test. In radiography, we ideally look for presence of radio opaque or radiolucent stone in NCCT, KUB, or IVP, and stone analysis. So indications for metabolic evaluation are recurrent stone formers, strong family history of stone disease, intestinal disease, pathological skeletal fracture, osteoporosis, history of UTI, personal history of gout, infirm health, solitary kidney, anatomic abnormalities, renal insufficiency, or stones composed of cysteine, uric acid, and struvite. In addition to it, all children should undergo a full metabolic evaluation. So some races like European, East Asian, and African have low relative risk, whereas Arabic, West Indian, West Asian, and Latin American people has high relative risk. Anatomic abnormalities which predisposes to increased risk of stone recurrence. They are horseshoe kidney, calaceal diverticulum, PUJO, medullary sponge kidney, urinary diversion, and solitary kidney. So metabolic evaluation of high risk and recurrent stone former. The AUA defines recurrent stone former as patients with recurrent stone episodes and multiple stones at initial presentation. So they recommend that clinician performs additional metabolic testing in high risk patients or interested first time stone former or recurrent stone formers. So metabolic testing should consist of one or ideally two 24-hour urine collection obtained on a random diet analyzed for at least pH, calcium, oxalate, uric acid, citrate, potassium, sodium, and creatinine. But despite these guidelines, prevalence of metabolic testing in high-risk stone formers remains low. So ideally, this should all things be seen in a 24-hour urine collection. These are the normal urine parameters of the various things which are required for testing in 24-hour urine analysis. This is an example of the patient report. These are collected on 2 days on a random diet. So first we see the volume. It is 2.35 liters. It should be around 0.5 to 4 liter. So if it is less, then we recommend to raise it around 2 liters. Then we see calcium oxalate concentration. So the normal calcium oxalate concentration should be 6 to 10. It is high. So we will recommend to raise urine volume and add citrate. So we see 24-hour urinary calcium excretion. It should be less than 250 in men and less than 200 in women. So as this is high, we should recommend, we can consider hydrochlorothiazide or chlorthalidone in BD. Next is urinary oxalate. The normal should be less than 40. So in this report, it is around 50 to 60. So if it is mostly dietary or if it is enteric, we can consider adding cholesterol and oral calcium 1 to 2 gram with meals. If there is greater than 80, it is a case of primary hyperoxaluria, which is very rare case and needs specific therapy. Then the next we see is urinary citrate concentration. It should be greater than 415 men and 515 females. So it is bit low. So we can consider adding potassium citrate 25 milliequivalent BD. Next we see is calcium supersaturation of calcium phosphate is 0.95, 0.5 to 2 is the normal value. It is roughly in the normal range. Then next we see pH. It is 5.72. So it is less than 5.8. So we can consider adding sodium citrate, 25 milliequivalent BD. If it is greater than 8, we can consider a possibility of urea splitting organism. Then the next is uric acid concentration. It should be 0 to 1. It is 1.6. So it can result in uric acid stone. So you should treat with alkali. Then there is okay. So these are the ways of analyzing and treating a urine analysis report. So then how should it be collected? The patient should choose a day when all voids can be completely captured and when the specimen will represent a typical day. Number of samples, 1 or 2 random samples on a random diet. The first morning void is discarded. Urine must be collected in appropriate lab provided container. Next morning, the first morning void is collected with rest of the specimen. And along with it, the total urinary creatinine should be measured to provide an internal check. For males, it is 20 mg per kg and females 15 to 20 mg per kg. Patient is instructed to discontinue any medication known to interfere with metabolism of calcium, uric acid or oxalate like vitamin D, calcium supplements, antacid, diuretics, acetazolamide or vitamin C. This all should be any current stone medication should be discontinued, or 2 random 24-hour urine samples are collected and obtained when the patient is on a random diet. So potential causes of falsely or erroneous 24-hour collection. This is an improper use of preservatives, failure to collect a full 24-hour urine, change in patient diet for the sake of study, intermittent indiscretions in diet, failure of specimen to accurately represent typical day, and bacterial contamination. Nextly, there is a stone analysis. It is more practical to obtain than a 24-hour urine collection. It is good adjunct to serum and urine metabolic evaluation. AUA recommends that stone analysis at least once when it is available to help classify patients and guide preventive measures. There are several methods of performing stone analysis. These are X-ray diffraction. First, that it is turning the stone into a powder before analysis. But when the stone is destroyed, microstructure and different composition related to one another cannot be evaluated. Then second is gross morphological analysis. And third is a micro-CT. It is a preferred technique. It is a non-destructive imaging technique whereby small structures such as stone can be visualized 1,000 times the resolution of clinical CT scanners. It allows for identification of mineral subtypes with roughly the same accuracy as infrared spectroscopy and prevents the microstructure. So this is an example. The light area represents uric acid stones. In the bright area, it is calcium oxalate monohydrate, and the relatively more brighter is apatite stone. So these are the diffraction techniques revealing a 7 mm stone analysis. So general measures of which are recommended is increasing the fluid amount to 2.5 to 3 liter a day to ensure a diuresis of 2 to 2.5 liter per day. Balanced diet should be considered rich in vegetable and fiber, calcium content around 1 to 1.2 gram per day, and salt content restricted to 5 gram per day. Animal protein content restricted to 1 gram per kg per day. Retain a normal BMI level, adequate physical activity, and balancing excessive fluid loss. This is the treatment algorithm summary. If there is a stone episode, so we should evaluate if it is resolved or not. If there has been a previous episode, we look for onset of stones, rule out bowel disease, gout, diabetes, medication, and family history. We do a serum study and 24-hour urine markers. If it is uncomplicated calcium stone, we will check for urine analysis. If there is normal calcemia, no bowel disease, no UTI, then we advise potassium citrate supplementation. If the calcium stone disease is associated with hypercalciuria, then we can give thiazide. With potassium citrate, if urinary citrate level is normal, or with potassium if it is decreased. Then if there is other stone disease, we should check for hypercalcemia. If present, rule out hyperparathyroidism. If uric acid is present, start potassium citrate. If he relapses, you can start allopurinol. If there is hyperuricemia, rule out gout and start allopurinol. If there is cystinuria, we can increase fluid intake and add thiola. If there is infection stored, start on antibiotic and add acetahydroxyaminic acid for severe disease. Thank you.
Do you know of any institution in this country, Sujata? Hello, Sujata?
Yes, sir, I'm here.
Do you know of any department in this country where they have a dedicated stone clinic? When I say dedicated, means like what people like Charles Pack and all these fellows had. Remember, Charles Pack is not a urologist, he's a physician.
No, sir, I don't think.
This is what happens, We are a country of doers. We want to take out the stone from the backside, from the front side, from here, there, but nothing. No further input is given. Whatever we have gained from all this knowledge is fellows, we have done the same study years ago. We have not progressed beyond that. We have not progressed one bit beyond what all these fellows have told us. The controversy whether I will treat one single stone former first time and evaluate what do all that is going on.
No, that's where the entire argument is. Actually, when a urologist is asked to talk about metabolic workup, it is not the forte of urologist. Though urologist does. Because this whole topic is under this controversy. Whom to do, basically. You will be wasting money on patient by just doing tests without getting proper treatment. That's the first thing. First thing you have to understand is whatever test which you are doing, whether it is starting from simple blood workup to hormone analysis to 24-hour urine, you don't have that kind of a controlled lab. It gives you a proper quality control reports. So you will be wasting time. That's why the patient actually loses out why he has to do the test. When you say at the end of the day that all the tests are okay. So it is again based upon how a clinician looks at it, select the cases on the risk assessment, not the risk assessment which is given. All this is humbug. So, I also presented on this topic just because I have to teach. But if you ask me, I will say that all these risk factors have to be there in the back of your mind. But that doesn't make you decide to do all these tests. So that's where, you have to pick up. You need to have a better indices to pick up the cases if I have to do metabolic.
Can I ask a question? What's the rationale of the stone metabolic evaluation? Somebody recurrent UTIs. There's something in your presentation. You said it's one of the indications to do metabolic evaluation.
If the stone is the cause for the recurrent stone is the cause for recurrent infection. Because that patient will have a double-edged sword which is working and produces greater parenchymal damage. So he is the one who needs to be looked at why he is forming stone, not as an infection stone form alone. So again, if you have to classify, you have to understand that these calcium and non-calcium stones. Non-calcium stones, most of the time you don't require metabolic workup because you know it is. Like infection stone, whether it is uric acid stone, whether it is cystine stone, once you have done that, you know, you don't have to go and do a complete other 24 workup on that. But there is a complex situation. That is the time when you have treated the patient. And then there's this patient, despite of treatment, comes back with stones again. Then you don't understand why he is. You have done all the things which are required. That is a time you need to be looking at. Because it is not just a single event. Cystine stone former can also have oxalate stone. We have seen in our own population. We have patients who have cystine stone. He has gone all around the world. He has gone all around the world, met all the people, and despite that, what is finally advised?